Good evening, everybody. Thanks for joining me for this GAPP MASLD Community Network presentation. I want to thank our sponsor, Madrigal, as always, for their support on this. So tonight we're going to talk about the difference between MASLD and MetALD. Again, my name is Patrick Horne, and for those of you who don't know, I am a nurse practitioner here at the University of Florida in Gainesville. If you could, real quick, if you could take a picture of this QR code, just to record your attendance for the meeting, that'd be greatly appreciated. I'll leave it up here for a few minutes or seconds, I should say. Okay. So we're going to, as usual, we're going to do a case study. So in this case, we have Ashley, who's a 52-year-old Caucasian female. She was referred to you for evaluation of a further evaluation after an abnormal ultrasound showed mild hepatomegaly and increased hepatic echogenicity consistent with hepatic steatosis. She otherwise feels well. As I mentioned, she's 52, she's Caucasian, and her BMI is 29.4. This is her medical history. So she has a history of polycystic ovarian syndrome, PCOS, as well as hypertension, hyperlipidemia. Social history, she does drink an average of 2 glasses of wine per day. On physical exam, not a whole lot. You do feel a smooth, non-tender liver edge, but otherwise unremarkable. And her medications are listed here. So amlodipine for her hypertension. She's on atorvastatin for her hyperlipidemia. And then she's also on a multivitamin. And then she's on milk thistle, which I see fairly common these days with a lot of my patients. There are vital signs. A little bit elevated blood pressure, especially the systolic of 140. And I apologize, that should say heart rate, not respiratory rate, but a heart rate of 76. Normal temperature, height and weight and BMI are listed here. Labs, I think pretty typical for someone who may have steatotic liver disease. You see maybe a mild to moderate elevation in the AST and ALT, maybe a mild elevation in the alkaline phosph as well, a borderline sort of total bilirubin, but a normal platelet count, hemoglobin A1C below 6, and triglycerides of 185. So we do a transient elastography, aka FibroScan, and this is what we get. So we get a liver stiffness measurement of 11.4 kilopascals. So looking over to the right, that puts her in the significant fibrosis or F3 category based on transient elastography. And then her CAP score is also elevated at 310. So that puts her in the severe steatosis range. So based on the transient elastography, we have a patient who is suspected to have significant fibrosis as well as a severe amount of steatosis. So just to kind of recap, based on the current nomenclature, so we have our overarching title of steatotic liver disease, and then that's broken down into several subcategories. So all the way to the left of the screen is our MASLD and our MASH, so metabolic dysfunction associated steatotic liver disease, and then obviously steatohepatitis. Real quick, I'm going to shift a little bit further to the right to the smaller blue box where we have alcohol-associated liver disease or alcohol-related liver disease. So the two very different things. And in the middle, which is what we're going to really focus on tonight, we have this combination of risk factors for MASLD as well as risk factors for alcoholic liver disease. And that's what's now called MetALD. So that is patients who have metabolic risk factors, which we're going to talk about for MASLD, but also consume increased amounts of alcohol above the recommended daily limits. So you have this combination of both MASLD risk factors and alcohol risk factors leading to a combination MetALD. So just to remind everybody, these are the equivalents of different alcoholic beverages. 12 ounces of beer is equal to about almost 9 ounces of malt liquor, 5 ounces of table wine, etc. Just to give you an idea, and obviously this is very important as you're just talking to your patients about their alcohol use, trying to get an idea of when they say they have one drink a night, what does that really mean? Are they having one beer a night? Or are they having, a 15-ounce glass of table wine? Well, that's more than one drink a night. So important to understand what constitutes one drink, so you can better understand exactly how much alcohol a patient may or may not be consuming. So some of the key pathogenic mechanisms. It's really a dual etiology. So over to the left, we have in this study was done before the nomenclature change. So this is NAFLD, same as MASLD, but we have these risk factors for MASLD: insulin resistance, diabetes, obesity, visceral fat, etc. And then you also have alcohol intake. So those two both lead to impaired lipid handling within the liver. That in turn leads to oxidative and endoplasmic reticulum stress and ultimately cell death. That then leads to this inflammatory response. But at the same time, when you have MASLD and ALD related, or when there's alcohol consumption along with MASLD, you're also at the same time getting interruptions in this in the intestinal microbiome. So you've got ethanol production, you've got lipopolysaccharides, and you've got microbiome derived products, again, leading to that inflammatory response. And both of those together ultimately lead to sort of accelerated fibrosis and disease progression. So it's sort of a two hit theory. You've got MASLD risk factors, but you also have alcohol as a separate component, both coming together and really enhancing and accelerating that fibrosis. So drivers of liver disease. So I mean, this probably goes without saying, but the more advanced fibrosis you have, the higher your risk, and in this case, over a 5-year period, the higher your risk of having decompensation. And the more factors playing into that, MASLD and alcohol, aka MetALD, two mechanisms, if you will, all increase the likelihood. And you can see that the alcohol consumption listed below breaks down how to categorize someone as, is it MASLD with maybe a little bit of alcohol? Is it truly alcohol-related liver disease, or is it more this MetALD? So detection of alcohol. So obviously the best way to detect alcohol use is through taking a thorough history, right? Asking patients how much do they consume and really diving deep into, again, what type of alcohol, how many drinks a day, how big is the glass, etc. One of the hepatologists I work with, one of the questions she likes to ask her patients who are wine drinkers is how many days does it take you to finish a bottle of wine? Because that will give you a much better idea and sense of how much they're consuming in a daily basis. There are questionnaires that have been around for a long time that are very, very accurate, very, very good. AUDIT-C, for example. And then we've also got blood tests, and we're going to talk about PEth specifically coming up. But as you can see here, moderate to excessive alcohol use or alcohol consumption in this particular study was found in almost about 30% of patients with MASLD. So it's very common. If you're not asking about it, you really need to ask about it, and you really need to drill down into the specifics. So what are our gaps? Well, again, it's trying to isolate who are the patients who just have MASLD, who are the patients who truly have ALD, and then who are these patients in the middle that have MetALD, have a little bit of both. So again, we talked about having those risk factors for metabolic dysfunction for MASLD. And so those are over there on the left in sort of the tannish box, if you will. So that's an elevated BMI, which, going back to our case study, our patient does have. They could have a fasting serum glucose, impaired fasting serum glucose, so over 100, elevated blood pressure, elevated triglycerides, or a low HDL. And they only have to have one of those 5. They can have up to 5, but they really only need one of those 5. And one of the things to keep in mind is if you have a patient who has just an isolated high blood pressure or maybe an isolated high triglyceride level, you need to think, is this really MASLD, or is this maybe more ALD or a MetALD component? So that's one of the first questions you need to ask. If the answer is no, if they have something else, then it's in addition to, then it's probably MASLD. But if they only have, say, high blood pressure, then you really need to dive into the alcohol consumption. If there's clearly no history of alcohol use, again, we're back to MASLD. But if there's any component of alcohol use, this is where possibly PEth testing could be really helpful. Some people, as we know, underreport their alcohol use. Most patients, I think, have a tendency to do that. So PEth can really give us some information, or more helpful information, to sort of guide us. So again, using PEth, and you can see the breakdown here Whoops, excuse me. Looking at the gray and the blue boxes. So alcohol use, but depending on men or women, 140 to 350 grams or 210 to 420 for women versus men. You're looking at a PEth probably around 25 to 200. That's going to be more that MetALD. If you get a PEth above 200 in males or females, and that would equal out to be greater than 350 grams a week for women or greater than 420 grams a week for men, that's more into the ALD side of things, not so much the Met. So a PEth between 25 and 200 really is more for that MetALD category. So back to our case study. So we do a PEth on our patient. She did report that she drinks an average of 2 glasses of wine per day. That's more than is recommended for a female. And her PEth is 120. So again, it's right in that range, that moderate to heavy alcohol consumption. So we know she has metabolic risk factors. She has an elevated BMI. She has hypertension. She has PCOS. She also has hyperlipidemia. And now the alcohol consumption in her PEth puts her into that moderate to heavy alcohol consumption. So really looks like we're dealing with a patient with more of a MetALD versus a MASLD or a pure ALD. So a little bit more on PEth. So I like to describe it, and I've heard others describe it this way as well, as sort of like the hemoglobin A1C of alcohol consumption, if you will. And the reason I use that analogy is it persists over time. And actually, as you can see here, rises over time, especially compared to a blood alcohol content or BAC. So with a blood alcohol content, you get a rapid rise around 2 hours, and then you get a steady decrease. Where with a PEth, you're actually getting an increase over an 8-hour period. And the PEth is actually detectable out to 12 days. So it's a very good indicator over a longer period of time of sort of the alcohol consumption of a patient. There's really no there's no variability or difference between sex, men versus women, as you can see from the scatter plot, or BMI. So this was a study looking at alcohol use in patients who were overweight. So they ended up screening a large number of patients, 659, but for various reasons, patients either didn't qualify, they weren't drinkers, there was data missing, they didn't meet the criteria for this study for alcohol consumption. So they ended up analyzing a total of 97 patients that they thought had suspected MetALD. And you can see there that females, there were 11 females that consumed anywhere between 140 to 350 grams a week. There were another 21 that had a PEth greater than or equal to 25. Men, again, 9, somewhere in that 210 to 420 grams per week consumption, and 56 had a PEth above greater than or equal to 25. And so what they concluded is that there was about a 16% of these patients were at risk for MetALD based on this data. So pretty high number. So again, I already alluded to this, but medical history, Ashley here does have metabolic risk factors, PCOS, which is associated with steatotic liver disease, obviously hypertension and hyperlipidemia. So we're dealing with not only MASLD, but then we've got this alcohol consumption, hence MetALD. So this is digging in a little bit deeper about the association between alcohol and hypertension, going back to where I was talking about that isolated hypertension finding. So this was a review of 32 randomized control trials, large number of patients, over 760. And what they found is that alcohol actually has a biphasic effect on blood pressure. So initially, in the first 12 hours after alcohol consumption, you actually see a decrease in blood pressure. But after 12 hours, so 13 or more, you actually then see this sort of rebound and increase in blood pressure. And so that's one of the reasons that this isolated high blood pressure with really no other metabolic risk factors per se should sort of raise your suspicion that are we dealing, what is their alcohol consumption? Same thing with hypertriglyceridemia. So this was a study looking at over a 10-hour period, and patients were either administered 2 standard alcoholic drinks or to placebo water, basically. And they broke it out into people who had baseline high triglycerides and a group that did not. But in both groups, whether you started with high baseline triglycerides or you didn't, in both cases, the group that was given the 2 drinks of alcohol had higher triglyceride levels over time, and they persisted to remain high compared to those who just received water or placebo. So another reason that isolated hypertriglyceridemia could be a tip-off that of more alcohol consumption than what they may or may not report. So just to kind of recap our case, this kind of covers everything we've talked about. Again, 52-year-old Caucasian female, risk factors for steatotic liver disease and MASLD, including elevated BMI, PCOS, hypertension, hyperlipidemia. On top of that, she's drinking around 2 glasses of wine per day. And I say average, so it could be more, could be less, but we know that's more than what the daily recommended dose is, and we also have objective information showing that with a PEth of 120. Transient elastography is concerning for significant fibrosis, in this case F3, as well as significant steatosis. So with all that, as I've kind of talked about throughout the whole presentation, we really can make a diagnosis of not only MASLD, but predominantly MetALD because there's a combination of both. So let's talk about some questions. So what are the current treatments? So we've got 2 components, right? We've got the MASLD and we've got the alcohol component together making MetALD, but we still need to address both sides of this. So from the MASLD side, it's going to be the same things we recommend with any patient with MASLD. So diet, currently the guidelines recommend the Mediterranean diet. We also are going to recommend exercise, and the goal is weight loss. Ideally, 7 to 10% weight loss, though there is benefit with even 3 to 5% weight loss. What about candidacy for resmetirom? Well, I mean, again, you're dealing with a MASLD component. She has F3 fibrosis per her FibroScan. That's right in line within the criteria to start resmetirom. So this is something I would have a conversation with the patient about. Again, treating the MASLD component as well as now going into treating the alcohol component, which that is a little bit more straightforward and simply it is ideally would be to stop. Cutting back is one thing. That's a start, but ideally the best recommendation in this case would be to stop all alcohol completely. And then does she need screening for hepatocellular carcinoma? This is controversial. She does have advanced fibrosis per the FibroScan, not necessarily cirrhosis. If you look at her other markers, sort of indirect markers, there was no mention of anything like splenomegaly or signs of portal hypertension on the ultrasound. Her platelet count is normal. So while some people will screen for HCC, the current guidelines don't recommend it. There's just not enough data to support it. But I would say in this case, I don't think you're wrong to do it, but the guidelines aren't currently recommending it based on her being F3. Obviously, if she was cirrhotic, F4, then that's a different story and that's a no-brainer. So what about this creating the ideal definition for MetALD, specifically for clinical trials? So we've got to try to overcome this underreporting of alcohol use, and the PEth may be helpful with that. We need to standardize the assessment. So whether that's an AUDIT-C and a PEth, whatever the case may be, we need to make it universal so we really can compare apples to apples, for example. And then we need to how do we certify true alcohol abstinence? Is that through a negative PEth? What is the process of doing that? And then we have to ensure that the drivers of liver disease are present. So looking for those cardiometabolic risk factors for MASLD. Do they have one or more of these? And again, teasing out maybe that isolated hypertension or that isolated hyperlipidemia, and whether that is more of a component of the alcohol consumption, not necessarily a component of the cardiometabolic syndrome. And the really way to tease that out is if the patient if the patient does truly stop all their alcohol and one of those still persists, then you're looking at that's probably more a cardiometabolic risk factor, not so much an alcohol component, obviously, because you take the alcohol part of it out. And then, consider exposure to risk factors. So, um, you know, looking at the criteria during, you know, 6 months to a year prior, what is sort of their risks, what is sort of their exposures. So my take-home messages, if you didn't already know, there is a new definition, MetALD. So these are patients with risk factors for MASLD, steatotic liver disease, but also have an alcohol intake that is somewhere in the range of 140 to 350 for women, or 210 to 420 for men, respectively. Um, we probably underestimate the amount of Met ALD, as well as probably we underestimate the amount of alcohol-associated liver disease as well. Biomarkers such as PEth specifically may be able to help us no longer underestimate, but that is something that I think does happen a lot. And then looking for those drivers of liver disease. So looking for those cardiometabolic risk factors and reassessing for those over time, especially after alcohol abstinence, to see if this was mainly if their condition is mainly being driven by the alcohol component, or is it also the underlying MASLD as well on top of alcohol. And then consider adequate exposure to these risk factors. So things like diabetes, hypertension, hyperlipidemia, obesity, etc. And then we need to try to really come up with better criteria for clinical research, and really focus on objectively identifying Met ALD diagnosis and figuring out how to compare those across different sociocultural, socioeconomic realities to try to come up with really a universal um, definition that fits various cultures. And so I'll just conclude with, if you would like any more information, please feel free to visit the GHAPP MASLD Community Network. There's additional disease state education information on there, as well as specific information on resmetirom or Resdifra. And I'll leave this QR code up for a second if you want to scan it. And with that, I want to thank you, and I will open it up to any questions you may have.